It looks like we've got a good number of people here, and there'll probably be some more logging in pretty soon. But in respect of everyone's time, we'll start right at 7:30. Welcome to the August Valleywise Grand Rounds. We are very excited this morning to have Dr. Rastogi with us. Dr. Rastogi is the director of the Concussion Program and the Pediatric Headache Medicine Fellowship at Phoenix Children's, and she is frequently recognized as one of Phoenix's top doctors in pediatric neurologies. She is recognized as one of the most influential women in Arizona business and one of the 48 most intriguing women in Arizona. At the Barrow Neurologic Institute at Phoenix Children's, she's developed and implemented headache and concussion forms, migraine action plans, as well as revising the headache management pathway. While highly involved at PCH, she's also very engaged nationally and internationally as a speaker for the American Headache Society, which brings us with us today, as well as serving on the editorial board for Headache and Neurogenic Pain section in the Frontiers of Neurology. She recently co-authored a chapter on chronic daily headaches. Needless to say, we are greatly appreciative of Dr. Rastogi joining us this morning to discuss the recommendations from the American Headache Society regarding first contact. For a little bit of housekeeping, please remember to keep yourselves on mute. And Megan will be putting the CME code in the chat starting about midway through the talk, and she'll also be putting the link to our survey. Please put any questions you have in the chat, and I will be keeping an eye on that. And with that, I will hand it over to Dr. Rastogi.
Thank you, Dr. Maurice. I appreciate that. Thank you, everyone, for having me this morning. I'm really excited to talk about migraine in pediatrics, which is my passion. I have quite a few slides today. I'm going to try to go through them the best I can. And if I could get this to advance. Okay, and these are our learning objectives today. I'm going to quickly skip through those. So let's start off by talking about what is migraine. So migraine is an inherited disorder characterized by attacks, including a variety of neurological and gastrointestinal symptoms with or without a severe headache. Neurologic symptoms may include sensory, vestibular, and cognitive disturbances. So when we all think about migraine, sometimes we may think it's just a headache, but it is a lot more than just a headache. There are a lot of different symptoms and things that come along with it that we need to think about when kids are having migraines. So we're going to talk about that a little bit more. So there are phases of a migraine attack, and migraine may start with premonitory symptoms such as mood changes, cognitive changes, feeling fatigued, and that can last for hours to days before the actual migraine symptoms begin. Some people can get an aura with a migraine, and these are fully reversible neurologic symptoms that can last up to an hour. Often these are going to be visual aura, so it's going to be some sort of vision changes like a scotoma, or patients will describe flashes of lights or colors in their vision. And then often for most people who have migraine, the headache starts. And the headache itself can last anywhere from 2 to 72 hours. And associated with the headache, you can get those other symptoms such as throbbing pain, nausea, vomiting, photophobia, phonophobia, mood changes. And then there's a postdrome phase, and that again can last anywhere from 24 to 48 hours, where people just don't feel right after the migraine happens, even though maybe their headache has resolved at this point. So if you look at these phases of migraine attack, you'll realize when your patients are having migraine that it may not be just the 4 hours that they're having the headache that they're not feeling well. Migraine can affect children for days at a time. And so we have to also think about when do their symptoms start and when do their symptoms actually end when we're treating migraine. So the pathophysiology of migraine is not well understood. It was thought to be a vascular phenomenon, but we know there's much more going on when a migraine occurs. There are pain-sensitive structures such as the dura and the blood vessels, which are innervated by the trigeminal nerve. So there's transmission of activity through the trigeminal nerve to the trigeminal ganglion and then to the trigeminocervical complex. And from there, there's further transmission of activity to the cortex and the thalamus. And that's where we think a lot of the neurologic symptoms that are part of migraine are coming from. So it is pretty complicated, still not well understood, but they're continuing to work on learning more about what the pathophysiology of migraine is. So the World Health Organization estimates about 1 billion people worldwide have migraine. And migraine affects 1 in 11 children. In adults, 1 in 5 women and 1 in 16 men have migraine. And the World Health Organization has also noted that migraine is the second most leading cause of disability in women. And so I think as pediatric specialists and pediatricians, we can actually do something to prevent this disability that occurs when children are older, if they present with migraine during childhood. And that's why I think it's very important to be able to diagnose and treat migraine early in life. There are various episodic syndromes that can be associated with migraine that we think occur in a very young age, even before children can tell us that they have headache and other symptoms of migraine. There have been studies showing that colic can be a predictor of migraine, that children with migraine were 6.6 times more likely to have experienced colic as an infant, and that babies with colic often have a family history of migraine. So that can be something important to ask parents about. Does anyone have migraine in the family? Are we seeing early signs of this in the baby? There's also an episodic syndrome called benign paroxysmal torticollis, where infants start with tilting their head. They can be irritable and they can vomit, and then they get better. So again, these episodic syndromes, they occur, and then in between the symptoms, children are actually doing fine. And that's sort of a clue that they could be experiencing these migraine variants when they're younger. There's also benign paroxysmal vertigo, where again, children will have episodes of vertigo or dizziness. They may or may not be able to explain what they're experiencing. They can vomit and then they get better. And then cyclic vomiting syndrome, which you may have seen more of, again, can be a migraine variant where children have these episodes of cyclic vomiting. In between the episodes, they're doing fine. And same with abdominal migraine. So this is basically stomach pain that's an episodic nature, and they don't really complain of headache at this point. So just some things to think about when you're seeing those variants in children. So the prevalence of migraine over time. So you can see here that during childhood, it tends to be pretty similar between males and females. But as they get older, there's definitely a significant difference in migraine in females. The mean age of onset for migraine is around 8 years for boys and 9 years for girls. So actually pretty young. And often these kids don't get diagnosed that young. You know, they sometimes don't get diagnosed till they're older, but they can be, you know, they present to me, they're sometimes 4, 5, 6 years old when they start with migraine. I do see that boys tend to start earlier and sometimes grow out of them by the time they reach puberty, whereas for females, they can sometimes worsen when they reach puberty. So if you look at this chart here, the prevalence of migraine compared to other common pediatric disorders, migraine is up there with ADHD, which we see a lot of these days, more prevalent than asthma, which also I feel like it is a common thing we see in children. And so that's, again, something to think about, that a lot of kids out there are getting migraines. So it's something that you're probably commonly seeing in your practice every day. This is school-related disabilities. So children without headache in the red and children with headache in the red and children without headache in the green or blue. And you can see here that children with headache are pretty affected by the headache, and this can lead to school-related disability, including poor attendance, having school-related reported problems, and repeating a grade. And I think we see a lot of that in our clinic. There are a lot of kids missing tons of school because of their headaches, and it's not always necessary. So a lot of times we have to come up with a school plan to try to ensure that they're able to stay in school despite their diagnosis. So let's talk about migraine diagnosis. So this is the International Classification of Headache Disorder, which is in version 3. And talks about the qualities of the migraine. So often in adults, migraine will last 4 to 72 hours. The pain will be unilateral. It's usually pulsating or throbbing. It's a moderate to severe pain. Migraine is aggravated by routine physical activity. So a lot of times they're not able to work through the headache. They have to stop what they're doing. They have to go lay down, rest, sleep it off. You can have nausea or vomiting, or you can just have photophobia or phonophobia. Now, in kids, a lot of times symptoms are a bit different. We usually see bilateral pain. So kids will tell you, the pain is bifrontal or bitemporal. Their headaches can be shorter. They can be 2 hours. And so they don't necessarily need to meet that criteria of 4 hours. And a lot of times we have to infer their associated symptoms by their behavior. So I ask, does your child ask you to turn down the volume or say that you're being too loud when they have a headache? Or do they want to go lay in their room and turn the lights off? So they don't always tell you that they're having photophobia or phonophobia. Aura in pediatric patients, so the prevalence is estimated to be about 15 to 30%. Again, aura can last anywhere from 5 to 60 minutes. It often occurs before the headache, but sometimes during the headache phase, or sometimes even without a headache, they will experience an aura. And usually, as I mentioned, visual aura is the most common, but you can get other aura symptoms, which include sensory, like numbness or tingling, which is often unilateral. You can get things like just difficulty speaking, confusion, dysarthria. So those are symptoms that can occur as an aura. We don't consider blurry vision as an aura. So we often consider that a symptom of the migraine. So if they say they start with blurry vision, that's usually a migraine symptom. So what are headache red flags? When you're assessing for migraine, it's important to make sure you rule out the red flags. So there's a mnemonic called Snoopy. So any systemic symptoms, fever, myalgias, weight loss, secondary risk factors such as cancer or an immune deficiency, any neurologic signs, it's important to do a fundoscopic exam to evaluate for papilledema. And if you're not comfortable with that, sometimes if I don't get a good look, I send them to ophthalmology to double check and make sure if I'm concerned about red flags. If there's a sudden or thunderclap onset, that's something that we worry about. Or if they've had headache, but it's a new or progressive headache. So any change in quality of the headache, we have to think about the possibility that there could be something else going on. And same with the pattern change. And any precipitant. So if they don't have headache and then they perform some sort of Valsalva maneuver, or they're change in position, like going from laying down to standing or standing to laying down, and that brings on the headache, not worsens the headache, but brings it on, that's when we get a little bit concerned if that's a consistent pattern that we're seeing. And so these are reasons for considering imaging in patients. So when do you send them to the emergency room? So the thunderclap headache, if they have a headache that peaks in intensity in 60 seconds or less, or it's the worst headache of their life, although probably everyone's had the worst headache of their life, but if that's what they call it, you want to consider that if they're still dealing with a headache. A new onset intractable vomiting upon awakening. So a lot of people get migraine when they wake up from sleep. That's actually not uncommon. But if they're waking up from in the middle of the night while they're sleeping, not in the early morning, or they're waking up vomiting every time, that's a sign that we need to be concerned about. Of course, any abnormal neurologic exam or any provider concerns such as the systemic symptoms associated with headache. Yellow flags where you want to consider imaging or you want to consider referral are the younger patients. So patients younger than 6 years, although as I mentioned, I've seen migraines start at ages 4 to 5. And so obviously you want to look at the other kind of patterns. Is it episodic or is it progressive? Are they having any of the other red flags that you need to be concerned about? If they're having any new onset or change in headache pattern, as we talked about, New daily persistent headache is if they start with a headache one day and it's unremitting. It never goes away. That's where we want to image them to make sure we're not missing something. If they have a side locked headache, so it's continuous and it's just stuck there on one side. So for that, we think about what's called trigeminal autonomic cephalalgia, something like cluster headache, where they have autonomic symptoms, including redness of their eye, lacrimation, stuffy nose associated with the headache. We image those types of headaches, and those are very, very rare in kids. We don't really see those very much. As we talked about waking up from sleep and Valsalva or a positional headache. So the debate on imaging. So, do we want to image? Do we not want to image? Of course, we don't want to miss something like a brain tumor. That's the second most common childhood malignancy. The incidence is about 2.8 to 4.5 in 100,000 children. 1 in 10 will have headache as the only symptom. So obviously, don't want to miss that. A lot of times it provides the family and the provider with peace of mind. But what's noted is that with an abnormal neurologic exam, 2.3 had a CNS lesion requiring surgical intervention. And in this study that they did, no one with a normal neurologic exam required any type of surgical intervention for anything that was found. So, we have to think about that. We are sometimes going to find lesions that we just kind of follow. They're likely incidental, and that does lead often to anxiety, worry for the family, and cost of medical care, having to re-image them. So that's a reason sometimes to consider whether or not imaging is needed. Also, we don't like to expose children to radiation, so we like to avoid CT. CT is going to be great for ruling out something big like a tumor, but it's not going to show the fine details of the brain that we usually want when we're looking for something for headache. An MRI is expensive. We also don't want to expose children to contrast, which we try to avoid when we're ordering MRIs. And for younger children, they do require sedation or anesthesia. And as I mentioned before, incidental findings are common, and the chance of finding something that's clinically significant that would require surgery, it can be somewhat low. So again, think about it. If they meet criteria for migraine and they're episodic and they don't have red flags, we usually avoid imaging in children. So a lot of our kids are not getting any type of imaging for headache. The American Headache Society says if their headaches are consistent with migraine and they have normal neurologic exam and no red flags, then there's no reason to do imaging. And that's pretty similar for the Choosing Wisely campaign, which is an initiative of the American Board of Internal Medicine. The American College of Radiology has an appropriateness criteria for headache, which I think can be really useful if you're not sure whether or not to image. And I think my slide deck will go out to everybody, but there are QR codes here where you can actually access these links. So if that's something you ever want to access later on, you can. So we're going to talk now about treatment. So once you've diagnosed migraine and ruled out red flags, what's the treatment strategy? So we start with what we call SMART habits for migraine management. Some of us call this SEEDS, S-E-E-D-S, seeds of success, but it's going to be this pretty much similar thing. We talk about sleep, eating, physical activity, relaxation or stress, dealing with stress and triggers. So when we're talking about sleep, we want to make sure that the family understands that what the goal is for their child's age. I often find that parents don't know how much their child should be sleeping, and they think if they sleep through the night, then they're good. They're getting enough sleep. It's important to screen for insomnia and sleep apnea. For meals, we counsel on eating at least 3 meals a day, making sure that they're not, getting headaches because they're not eating properly or they're hungry or they don't get a snack at school. Hydration, again, we have to talk about goals. Most people don't know how much they should be drinking every day. And to ensure that they're taking a bottle to school with them, because sometimes they'll tell me, oh yeah, I drink lots of water. Would you take a bottle to school? No, I drink from the water fountain. It's probably unlikely they're getting enough water that they need all for the day. For physical activity screening or addressing obesity, that's really important, ensuring they're getting a good amount of physical activity per day and limiting screen time. Relaxation or stress are big triggers for a lot of people. And I think this is something that's really important. A lot of times we don't have the time during our visits to do this, but screening for depression and anxiety or screening for stressors. A lot of kids are stressed with school. And if this is really an issue for them and they're having a lot of headaches, we talk about doing things such as mindfulness, relaxation, maybe seeing a psychologist for cognitive behavioral therapy or biofeedback. There's a lot of evidence for those for pediatric migraine. They're actually very useful strategies. Triggers often can be hard to identify. I don't focus a lot on triggers unless they really know what their triggers are and trying to avoid those. Sometimes keeping a headache log can be helpful to identify triggers. And of course, we tell them to completely avoid caffeine. So caffeine can not only be a trigger, but you can also get caffeine withdrawal headaches if you're having caffeine on a daily basis. So these are things that can be done early on. I find this, this is usually my first strategy. By the time they come to me, I'm also starting them on medication, but I always address this stuff. And I say, this is something you need to deal with first if you don't want to stay on medicine for a long time. And again, behavioral therapies for migraine. So there's a lot of resources on this at the American Headache Society primary care website. If anyone's interested, you can go to that website. But in pediatric migraine, there's quite a bit of evidence that these strategies are helpful to reduce migraine disability in children. At Phoenix Children's, we do have something called a complex headache clinic. It does require internal referral from one of the headache specialists, but we do a 2 half-day clinics a month with one of our psychologists, Dr. Arnold, and we do have patients who are struggling quite a bit with the migraines or have some comorbid anxiety, depression, or other psychological symptoms, come to that clinic to work with her. So that's something we can actually offer our kids with migraine. We also talk about resources for families. Sometimes they just really don't understand that their child could have migraine at such a young age. A lot of people think this can only happen for adults. So we give them resources. The American Migraine Foundation is a great resource. Headache Relief Guide, even a great resource for kids. And so there are QR codes here if you want to access those sites. Those are helpful. Okay, so let's talk about acute treatment. So next step, if we're prescribing medication, there's 2 options. You can do a step versus a stratified treatment plan. And they find that stratified treatment plan actually is more beneficial to reduce headache over time. And so stepwise, you would start with first trying something that's non-specific for headache. And that means maybe like an NSAID, like ibuprofen or naproxen. If that doesn't work, then you would move to something that's more migraine specific, like you could prescribe a triptan. And then finally, you could try an antiemetic, because some of our antiemetics actually double up as migraine treatment. But I find, the evidence and, in practice, we find the stratified treatment plan is more beneficial for the patient. And this is where you're going to be treating them based on the severity of their disease. And so if they have mild headaches, often you will start with just ibuprofen or naproxen, so NSAID. Could be over the counter or could be prescription. You want to make sure that they're dosing appropriately. So always ask what dose they're taking. You also want to make sure that they're taking their medication right at onset of their migraine. So a lot of children and even adults, they wait until their headache gets really bad. And by then, the likelihood of something really working really well and completely providing pain relief is unlikely. And so you want to ask about when do they take their medication. when you're doing acute treatment. For more moderate symptoms, we usually recommend adding an antiemetic if they're having symptoms of nausea and or vomiting. And here I often will prescribe, I will do migraine specific treatments. So many times they come to us, they've already tried over the counter stuff and it's maybe not working. So I'll prescribe a triptan. For antiemetic, I start with Zofran, but it's actually the other antiemetics such as Reglan, Phenergan, Compazine that are, they do work for migraine. They have efficacy for migraine. My concern with those is that they usually make kids drowsy. So we start with Zofran, but then might consider moving forward with one of the other antiemetics if that's not working, or if they need better migraine relief in general. So these are guidelines from the American Academy of Neurology and the American Headache Society on acute treatment. This is evidence-based for pediatric migraine specifically. So ibuprofen, as I mentioned, can be something that you start with. Of course, you want to make sure it's dosed appropriately. There's also evidence for something called Treximet, which is a combination of sumatriptan and naproxen. I don't think Treximet is generic yet, so I personally will prescribe both a triptan and naproxen and tell them to combine them if that's something that we find is beneficial. And so for triptans alone, the evidence is just for the 2 nasal spray triptans, which are zolmitriptan nasal spray and sumatriptan nasal spray. And then for oral triptans, there's rizatriptan, which comes in an ODT formulation, and almotriptan. Now, again, these are the ones that have pediatric evidence. That doesn't mean that you can't use other triptans. You could very well use sumatriptan alone. You could use elatriptan, which is called Relpac. So a lot of times it depends on what's covered, what's on their formulary. The oldest ones are rizatriptan and sumatriptan. So those are the ones I usually start with, the oral tablet formulation, because those are going to be covered by insurance. And then, as I mentioned, the antiemetics, so the dopamine antagonists, like prochlorperazine, which is Compazine, promethazine, which is Phenergan, and metoclopramide, which is Reglan, all show efficacy for migraine itself. So those can be useful, usually used if they do have nausea or vomiting, but doesn't have to be. It can be used for the migraine in combination with the triptan plus minus an NSAID. So these are tips for prescribing triptan. So we usually talk about the rule of 2 when we're telling patients how to use their triptan. When you prescribe it, it's important to note on there that they can take a second dose after 2 hours. So I always say take the triptan at migraine onset. If you're still having the headache after 2 hours, take another dose. And a lot of patients don't utilize that second dose, which is something that can be given. They just can't take more than 2 doses in 24 hours. If they're consistently needing 2 doses, then you can start with them with a lower dose, but then bump up the dose so that they can take a full double dose at the onset instead of taking 2 doses every time. And then you want to aim for 2 days per week or less. And the reason for this is that triptans and other medications such as NSAIDs and acetaminophen are known to cause medication overuse headache. So if they're taking these medications more than 2 to 3 days per week, they could be getting medication overuse headache, which is actually an ICHD-3 diagnosis on its own. This is also known as rebound headaches, if you've heard of that. So often, they take the medication and then as it wears off, their headache could come back again. And so we do see this sometimes in our practice that kids are taking over-the-counter medications on a daily basis or sometimes 4 to 5 days per week, and they're just had a progression of their headaches since they started doing that. It's kind of interesting how you see that. The treatment for this is to actually either just stop the acute medication that they're taking, tell them to limit it, and that can often help by itself. But usually we're having to start them on a preventive medication if they're having that many headaches per week. Warn about potential side effects. So some people can get tightness of the face, and the neck or the jaw. They can feel hot or tingling. They can get flu-like symptoms, fatigue, or myalgia. So not most kids do fine on these. A lot of times their parents will say they experience these symptoms, but we still try them because the kids, a lot of times they're medication naive and they do pretty well with these. Sometimes you'll get a bounce back from the pharmacist and they'll say, well, they're on an SSRI and so they can't do a triptan with it, but that's actually not true. The American Headache Society has a position statement that says that you can give triptans in the setting of an SSRI or SNRI. They're going to be limiting how much they take it. So it's not something they're taking on a daily basis, so it is safe to use. You can counsel your patient on the possibility of serotonin syndrome, but again, it's so rare to happen that we don't usually talk about it. Also note that when you're prescribing triptans for kids for migraine, the insurance is going to limit how much you give them. So they usually limit to 9 pills per month. So when you're writing for it, you're going to dispense 9 tablets. And for the nasal sprays, it's even less. It's usually 6 sprays per month. When do you not want to use a triptan? You want to avoid triptans in cardiac or cerebrovascular disease. We also usually avoid them in migraine subtypes such as hemiplegic migraine or if they have brainstem aura, although more and more these days there are reports that triptans are safe to use. So usually that's in the setting of a headache specialist. We will, try a triptan for these patients. And then if they have uncontrolled hypertension or severe hepatic impairment, you don't want to use a triptan. As far as FDA status, we actually do have some triptans that are FDA approved. We talked about rizatriptan already, which comes in an ODT formulation. This is approved down to the age of 6 years. So if you don't feel comfortable using a triptan in children, I would say this is the one to go for because you can say, hey, this is FDA approved, it's been studied, there's efficacy and there's safety. Almatriptan also has an indication at 12 years and up. We talked about sumatriptan and naproxen, which is known as Treximet, and then zolmitriptan, the nasal spray formulation, is FDA approved in adolescents and teenagers. These other ones are not FDA approved, but again, we do use all triptans and it just depends on their insurance, what's covered. Usually sumatriptan or rizatriptan first line. I would also, I guess that's not in here, but I'd talk about when to use a nasal spray formulation. Nasal sprays can be helpful if someone has pretty quick onset of their migraine. So they say that their headache goes from like a 0 to an 8 or a 10 really quickly. They're going to work faster because of the way they're delivered right to the nasal mucosa. They can also be used if there's a lot of like nausea or vomiting. So it bypasses the GI system, which is really nice. You don't have to wait for it to go down and be absorbed there. So that can be really helpful in that setting. A lot of times insurance does want you to try an oral formulation before you do a nasal spray formulation. So again, you might get a denial, but sometimes it's worth trying if patients have those types of symptoms with their migraine. Okay, this is a migraine action plan. This is something that was validated through the American Headache Society Pediatric and Adolescent Special Interest Group. There's a QR code here. This is a really useful tool to give to schools. I think it really helps the teacher and the school nurse, and it helps the family understand how to treat the migraine. We've actually developed our own migraine action plan, which we've embedded into our electronic health record system. So we can just do it within our notes and we can give it to the family. It's also available on the portal for them. Really useful tool. I think it's really helpful for them to know, when to take their medication, what medication to go for, what's their combination. It's important for them to keep their medications at school. That's one way that we deal with not missing school. If they have something that's effective, they keep their medication at the nurse's office, go to the nurse, take it, rest for a little while. And our goal is to be able to get back to class without having to be picked up and missing more school. So I would really encourage use of this. I think it's very, very helpful. Okay. All right, so again, I think we've covered most of this, so I'm not going to repeat it. But if anyone has any questions, of course, I'm happy to talk about this. If they don't respond to one triptan, we do switch to another. So we do kind of, usually we'll try at least 2 to 3 triptans. And then if that doesn't work, we might switch to a different type of NSAID like diclofenac or ketorolac, and or, add a dopamine antagonist. So it's worth trying more than one triptan. Okay, so next we're going to talk about migraine prevention. So when do we prescribe preventive therapy? Of course, we want to start with the SMART treatment or the seeds of success, but sometimes kiddos are having so many headaches, we just need to start them on preventive therapy. We do start preventive therapy if they're having anywhere from 4 to 6 headaches per month or 1 to 2 days per week. So a lot of people think, okay, if they're only having like daily headaches, we would start preventive, but that's actually not true. What we want to try to do is prevent progression to frequent headaches or to chronic migraines. So if they just have episodic migraines where they have less than, let's say, 4 headaches per week, we want to prevent that progression, because sometimes if you don't treat them, they're going to progress and they're going to become more frequent just by the natural pattern of migraine. We also might prescribe preventive therapy. Maybe they don't have that many migraines, but they're missing a lot of school. Let's say we're trying acute treatments like triptans and dopamine antagonists, and those aren't working. That would be a reason also to use preventive therapy. Okay, let's kind of work at, let's do this a little differently. Let's try to prevent these instead of chasing after them. And then sometimes it's just preference of the patient or parent. They may be having 2 days of migraine per week, but they may say, you know what, we're going to work on the lifestyle habits and we're going to wait to try preventive medicine. We don't want to be on a daily medicine. So, and I think that's reasonable, but I think it's important to counsel them that, hey, if these start to pick up, they become more frequent, or you're missing a lot of school, we really need to do something a little different about this. So this is when we would start preventive therapy. Sometimes we'll start with nutraceuticals. So maybe they prefer more of a natural route. They don't want to do medicine right away. So the most common ones that we use are riboflavin or vitamin B2, magnesium, and coenzyme Q10. For dosages, we all dose these a little bit different. For riboflavin, I usually start at 100 milligrams BID. Magnesium, I go with, for older kids, 400 milligrams a day. And for younger kids, anywhere from 200 to 250 milligrams a day. I dose it once a day. I like to use it in the evening time because it does have a calming effect. So for kids who have insomnia, or, they're just a little bit anxious before going to bed, we give them magnesium in the evening. CoQ10, I usually start with 100 milligrams daily, but you can go up to 200 milligrams. And melatonin has conflicting evidence, but we will sometimes use it if there is insomnia, if they haven't tried it before. And usually for insomnia, you're wanting to use low doses like 0.5 milligram or 1 milligram. But for migraine, if we're trying to use it for both, we'll go up, anywhere from 3 to 6 milligrams for the older kids. So, and then you want to just counsel them on, the possibility of having diarrhea or stomach issues with riboflavin. Magnesium. Magnesium is great if they have constipation. They like the idea of, something to help with both. We used to use an herbal supplement called Butterbur or Petacytes. We no longer recommend that because there was concern for liver dysfunction. Sometimes I'll have patients who are actually on this because some of the over-the-counter like migraine relief supplement combinations will have Butterbur. I had one patient who was on it, but it was working really well. And the mom said, I really don't want to stop this. She's doing so much better. So we're keeping an eye on her liver. We're just doing routine labs to make sure that we don't, see anything happen. For pharmaceuticals, so these are the common ones that we start with. Topiramate, which is an anti-seizure medicine. You do need to counsel on, not getting pregnant when they're on this, and we do recommend folic acid supplementation with topiramate. I usually divide topiramate BID. This is a target dose, 2 milligram. I do 2 to 3 milligram per kilogram per day. And what you want to know about if you're starting a pharmaceutical for prevention is that you want to start low and go slow. So that's really, we all go by that. You want to start a low dose and you want to titrate. So you don't want to just leave them at that dose, but you need to counsel the family on the goal. We're trying to reduce your headaches to less than 1 to 2 per week. So keep going up until you, feel like it's working. For topiramate, I usually titrate every 2 weeks. So I commonly do start 25 milligrams a day, just once a day, and then I go up to BID, 25 BID, and then 25, 50, and then 50 BID. But I only go up to, depending on their weight, to about 2 to 3 per kilo. And I tell them to stay at the dose that's working. For amitriptyline, we dose this before bed. It can make kids pretty tired. It's an antidepressant. You do want to warn them, talk to them about the black box warning for suicidality. Can help with mood issues, but it is a lot lower doses than what's used for depression. So I tell them sometimes it's just mood neutral, but it's nice when they can't sleep at night. It really does help a lot of kids if they have trouble with insomnia. It works for the migraine and for their sleep. Usually I'll start 10 milligrams at night, and then I'll titrate up to 1 milligram per kilogram. And then if I go beyond this, I do obtain a baseline EKG to monitor for prolonged QT. And then, and then an EKG after treatment. Propranolol and valproate don't have as much evidence in children, but those can be used. Of course, propranolol is contraindicated in asthma. I usually dose it BID. Just find it hard when they're in school to dose it TID. And then this is, of course, the goal dose. So you want to start lower, something like maybe 10 BID or 20 BID and work your way up. We avoid valproate or Depakote in females of childbearing age just because of the reproductive risk. And then also it can lead to other symptoms such as PCOS if they're using it chronically, and weight gain. So this is something I typically avoid. Cyproheptadine is a really great medication. The evidence is limited for kids, but we use it so much. A lot of us really like this, especially younger kiddos. It's an appetite stimulant. A lot of you may have used it for that purpose. And those little kids, a lot of times the parents will say, oh, they're such picky eaters and they don't eat properly at school and then they get headaches. So I really like this option and they often like it too. I actually dose it nightly because I think it does make them, does have some sedation. So I just do it once a day and it works just fine that way. It's available in liquid form, which is also great for the young kids who don't swallow pills. Okay, I'm going to talk about CHAMP really quick. So this was a study done based out of Cincinnati Children's Hospital, the Childhood and Adolescent Migraine Prevention. They were looking at the most commonly prescribed preventive medicines, topiramate and amitriptyline versus placebo. And what they actually found was that placebo worked just as well as topiramate and amitriptyline, and it caused less side effects. So they actually ended up stopping this study early due to futility. And a lot of us felt like we were out of jobs at this point because we're like, okay, this is what we do every day. We prescribe topiramate and amitriptyline. But I think bottom line, what we realize is that treatment is going to be different for every patient. And so it's important to mention this, that, okay, just starting something can usually help. And so whether you want to start medicine or whether you want to start nutraceuticals, we can go either way, but we should also incorporate lifestyle management and consider behavioral intervention too, and give headache education. So we're still using these medications despite this study. Topiramate is FDA approved in adolescents. So we do have that study where it was found to be efficacious and safe. And so we still use it, but we do make sure that we're incorporating all of this stuff in our treatment plan. Okay, so I think we talked about tips for use of preventive medicine. I think one big thing, I talked about discussing a goal with the family, but also telling them that, okay, this is not going to work quickly. So you're not going to be on it a week and then it's going to get better. We do a minimum of 2 months at the target dose. So once they titrate the dose, so that's an important part of the treatment plan, and then they're at a dose that seems to be working, we still keep them on it for a few months. So we want to make sure, because we see more efficacy as time goes on. So we want to tell them that. We want to say, this is not a quick thing. This is more of a long-term thing. Just stick with it. If you have side effects, call us. And sometimes, we can dose it a little bit differently to make it work, or we can start lower and go up slower. So all important things, because a lot of kids do end up stopping their medication because they feel like it's not working or they get side effects. And then after that, we do talk to them about, like, eventually our plan is to wean you off medication. So if they're doing really well, I like to treat them for at least 4 to 6 months. And then when I wean them off preventive medication, I do it when they're not in school. So mostly it's going to be summer break, but sometimes if they have like a long winter break or something, we'll wean off during that time. And that way it gives us a little bit of time to see how they're doing. Okay, so when to refer. So, we talked about red flags. And then I would say next, if things that you've started are not working, like if they've been on nutraceuticals for 2 to 3 months, or pharmaceuticals are not working, acute treatment, or you start them on a preventive treatment that doesn't work, then I think, go ahead and refer them over. We see a lot of kids, and our wait at this time is 6 months. And so I think if you have the comfort to start something for the patient, like we saw with the CHAMP study, just starting something often helps them. And just, discussing lifestyle modifications and things like that. It would be really helpful for us, if they've tried things before, or if they get better and then they don't need to see us, which would be great. It would help reduce our wait time. Again, we see a lot of kids who've not been started on anything or had any counseling or whatnot. And I know you guys are very, very busy in your practices. I know it's really hard to talk about all of this stuff and, the limited amount of time you have to see a patient, but bringing them back, have them keep a headache diary, start some lifestyle modifications, maybe some nutraceuticals, and have them come back in like a month and see how they're doing and then go from there. We do a lot of kind of novel therapeutics or procedures for kids who have not responded to 2 or more preventive medications. We do Botox for chronic migraine. So if they have 15 days or more of migraine per month, then they qualify for Botox. CGRP is calcitonin gene-related peptide. These are they're anti-CGRP medications, which are the newer medications. You may have seen commercials out there, Khloe Kardashian, or I think it's Serena Williams, for these medications called Nurtec and Ubrelvy. These currently are FDA approved in adults, but we're using them for kids. We often have to fight with your insurance to try to get them approved, but usually it's if they're not responding to the typical medications, topiramate, amitriptyline, et cetera. We're currently doing clinical trials for a couple of these medications, so that's something, if they're interested in, we can offer them. We do nerve blocks for status migrainosus. Our emergency department has an ED headache or migraine pathway. So if they're in status migrainosus and they're having continuous headache for more than 72 hours, they can come in and they can get a series of IV medications to help. And then there are neuromodulation devices. So a few of them are FDA cleared for adolescents. So we use those. There's remote electrical neuromodulation, which is called Nerivio. It's a band that they wear on their arm. And, the thought is that it sends feedback up to, the various nerves that are involved in migraine. They can sometimes wear that at school if they find that it's helpful when they have a migraine. And it gives them an option for something to treat with besides medication or in combination with their medication. There's also a non-invasive vagus nerve stimulator called GammaCore. That one's a little pricey, so we tend not to prescribe it as often, but it's an option. There's also single pulse transcranial magnetic stimulation. So there's a device that you can kind of hold to the back of your head and it provides magnetic pulses. And that can be sometimes helpful when they have a migraine. Again, a little bit pricey. So I would say we tend to go with the remote electrical neuromodulation quite a bit more for patients. Okay, I'm going to quickly touch on this and then I'm going to leave a few minutes for questions. So I think this does come up sometimes for females about contraception and migraine. So the World Health Organization says to avoid combination hormone contraceptives in migraine with aura. There is some thought that aura, back when we thought this was all a vascular phenomenon, thought that it was a vascular issue and that people who have aura can lead to stroke. So they've done a lot of studies and they've actually found a higher association in people who have migraine aura, with stroke. And so we do counsel these patients on that potential risk. A lot of times that risk is not in kids and there are no studies really for kids. They're all in adults, but we talk to them about it early because a lot of the teenagers are going to age out of our practice and go to adult practice, and we want them to know about this. So we talk about avoiding high estrogen. Again, the World Health Organization says don't avoid it. The American College of Obstetricians and Gynecologists says don't use estrogen at all. The International Headache Society says low dose estrogen is safe. And again, there have been studies done on this showing that. So, we'll usually recommend, let me go back, sorry. We'll usually recommend either low dose estrogen or progestin only or something alternative. I don't treat, if they want to start on contraception, I do send them either back to PCP or to gynecology. If you're using contraceptives for headache, so this is actually here is migraine without aura. Let's say they get frequent migraines. They're associated with their menstrual cycle. So either before, the premenstrual syndrome, they get migraines during that, or they get them with their menses. And that's a consistent thing where they notice it every time. We can sometimes recommend that they go on some sort of hormonal contraceptive where they skip the placebo pills. So they take it consistently. So basically they're not getting their cycle, and that is going to reduce their migraine disability. So again, that's a reason that you can use it. It's going to be very rare. We don't see a lot of kids with menstrual migraine, but it does happen sometimes. Usually their migraine is happening kind of at any time. So there's no specific pattern. Okay, and then again, this just kind of talks about the odds ratio for ischemic stroke if you're using, progestin only versus using certain doses of estrogen as well. So that's there. Okay, so in summary, migraine is as prevalent as other common childhood conditions. It's important to diagnose early. We should rule out secondary headache and the need for imaging, but most kids will not require that. Provide acute treatment and a plan for school with clear direction and specific goals. Definitely start with lifestyle management or the SMART or the seeds of success. That's really important. And also incorporate behavioral, nutraceutical, and medical treatment to prevent headache and limit disability. So there's a lot of resources on the American Headache Society website. This program called First Contact, the goal is to provide this education to primary care specialists to help them identify and treat migraine early. There's a QR code here, so if you get the slide deck, you can access that easily. And then American Headache Society does provide CME. I know you guys get CME through Valleywise, but if you want to access this and there's a survey, you can go ahead and do that as well. Okay, and that's it. I'm going to open the last few minutes to questions. If anybody, I know I went through a lot of information really quickly.
Thank you. That was very informative and helpful. I don't see any questions in the chat so far. One thing you had mentioned is it's about a 6-month wait for the appointments at your clinic, and you recommend starting therapy. At what point, knowing it's 6 months, would you recommend people start putting in a referral, knowing it's going to be a while before an appointment?
Yeah, so I think that if you feel that this may be a patient who's having a lot of migraine and that maybe starting with lifestyle management may not be as helpful, and they're probably still going to need to see us just because they're having a lot of migraines, they're missing school. I think putting in the referral is appropriate because it's going to take so long to get them in. But if there's things that you can do in the meantime to help them get better, and like I said, a lot of the kids are going to get better, just starting treatment, just seeing the doctor for these, and working on some good habits, and maybe, taking daily nutraceuticals. And then, if they don't need to see us, they don't need to see us at that point. And that may help, reduce the wait time as they're less patient seeing us. But if you feel comfortable, maybe they're having episodic migraine, they just have maybe one migraine a week or something like that. And you think maybe bringing them back in a month to make sure they're better, you can start there and then refer at that point if they're not getting better, if you've tried a few treatments.
And are you able to explain a little bit about the mechanism of action of some of the nutraceuticals?
Yeah, we don't fully understand the mechanism of action of these. We know for a lot of the medications that we use, they have various different mechanisms, the way they work. I mean, we use different classes of medications: anti-seizure, antidepressant, antihypertensive. They all have they have different mechanisms of the way they work. Some of them affect serotonin, some of them affect calcium channels in the brain, some of them affect sodium channels in the brain. So I can't say that we fully understand the mechanism of how they work. I do tell the families that. We know that the pathophysiology of migraine is not well understood also, so it's a little bit difficult from that standpoint also to understand. What I tell families is that what these do is they decrease the overactivity in the pain pathway in the brain. So if they're asking, well, how do these work? We say, we don't know exactly, but we think that's how it works. There's nerves involved, and there's pathways in the brain, and there's some overactivity happening there. And so that's what these things are doing for you. And I see another question. If nightly cyproheptadine helps a little, should we add an AM dose? You can. I just increase the dose at night. I keep it all once a day, and it seems to work just fine. But if you want to add an AM dose, you very well can. You just need to make sure it's not making them sleepy or tired during the day, because I do find that some of them do get tired when they take that medication. So, but absolutely. I start older kids, it comes in a 4 milligram tablet. I'll start them at 4 milligrams at night, and then we'll go up to 8, and then we'll go up to 12. And then if you want to be a little bit more conservative, you can cut the pill in half. So you can start them at 2, and then go to 4, go to 6, and then go to 8. And I think giving them a titration plan is nice, because they have something to work on and keep their headache diary and stuff like that. For the liquid formulation, it's 2 milligram per 5 ml. So it's pretty easy to dose. Again, for the little kids, you can start at 2 milligram, go up to 4, sometimes go up to 6 or 8 if needed. Okay. There's a question here or a comment. Interesting term, nutraceuticals. We use these therapies in IBD care too. It seems, oh, I'm sorry, I can't see it. It seems that term may be a little misleading, confusing for families. Yeah, so we don't say the word nutraceuticals most of the time. I call them vitamin supplements. We talk about that they're high dose, so they're not the type you're going to find in multivitamins, and they need to be high dose for them to work for migraine. And so for most people, they're going to be over the counter also. So I think that helps them understand that this is not a prescription medicine. I do actually prescribe magnesium if they have an access plan. So the Medicaid plans do cover it often. Sometimes they'll cover the riboflavin as well. So you can try to prescribe those. But I do tell families are over the counter, and we have a handout that goes along with it. So we like to utilize handouts a lot in our clinic. And so we have a little handout with dosaging to help guide them on what works, what they can get. from the store. Okay, I think I addressed all the questions. Dr. Maurice, did you see anything else in there?
It looks like we just got one more question
okay.
of any recommendations for the best form of magnesium.
Yeah, so it has to be chelated magnesium. So we usually recommend mag oxide, mag citrate, or mag glycinate. I think the glycinate version is less likely to cause the diarrhea symptoms. So that could be, if they're concerned about that, they can go with the glycinate. But if they're having constipation, then I think the mag citrate or mag oxide can work well for them. I'm happy to share the handout. It does have our Phoenix Children's logo on it and stuff, but if you want to use it as a source, I'm happy to send that out. So if you let me know the best way, and I can get that to everybody as well. Question from resident, the valproic acid, the low evidence is just for outpatient because we use it. Yes, correct. Yeah, we use it. We use valproate or Depakote as part of our emergency room migraine pathway. So there's definitely more evidence for IV formulation for status migrainosus. It's actually our step 2 of the pathway. So step 1 is using Toradol and Compazine, and then Benadryl to counteract side effects of Compazine. And then step 2 is using IV valproate. So yes, the limited evidence is for outpatient, and that's for pediatric only. So, and it's not our favorite to use just because of the side effects, but we can, it's an option.
I think that is all the questions that are in at this point. As far as accessing handouts, we will work with Dr. Hartley and PCH.
Perfect.
I know the presentations go online to the joint PCH website so you can access the presentation later. And then also we can work together to see if there's a way to make sure people can access the slides as well.
Okay, perfect. Thank you so much for having me again. If you have any questions, please reach out to me. So at Phoenix Children's, our emails are first initial, last name. So I'm rristogi@phoenixchildrens.com, and I'm happy to help if you have a specific case or just questions.
Thank you so much.
Thank you.